Good morning. My name is Dr. Asha Devereaux, and I would like to talk to you about the fourth dose, COVID-19 therapeutics, and something called long COVID. Most of the time will be spent for question and answer, but I thought I'd share with you some slides to frame the conversation. So let's first look at what's the current status in San Diego. We currently have 93% of our population has received at least one dose, and 82% are considered fully vaccinated. And what fully vaccinated means is that you've received 2 doses of the SARS-CoV-2 vaccine. Now, late last year, a third dose was advised since we learned that immunity wanes after about 12 weeks from the second dose. So, of that, pretty much everybody's been advised to get a third dose, and only 55% of San Diegans have received a third dose, and nationally, only about 30 to 35% of people have received a third dose. And that's what's created this recommendation for a fourth dose for our most vulnerable people, just because we have seen that it requires more than 2 doses of vaccine to provide some immunity against our new variant. So let's look at our current cases in San Diego. How much we are at risk determines on the prevalence of disease in the community. And currently, by reported cases, it seems like we're near 0 compared to where we were in January and February, which was the highest peak we've seen in the last 2 years. And these were all our confirmed cases, and this is a 7-day rolling average of rate of cases, and it's near 0 right now. However, if we compare that with what's called wastewater surveillance, which is something being done by the County of San Diego epidemiological branch and a research. And what they've seen is that there's an uptick in COVID Omicron variant, BA2 noted in wastewater surveillance. And it is about 55% in San Diego County, and it is concerning that there's this uptick even though reported cases are lower. And the reason is most likely because 2 reasons. One, the Omicron variant has minimal flu-like symptoms. It's short-lived. Many people feel like they've only got allergies. And second, that home test kits are turning positive, or people are using home test kits to determine their disease and not even reporting it. So those are likely the reason why we're seeing this discrepancy, and I suspect we may see more as time goes on. So let's look at the case rates by vaccination status. We do know in our Omicron surge in January, those who were not fully vaccinated, means 1 dose or none, had a much greater increase risk of getting infected than those who had been vaccinated or boosted. Now, this discrepancy, you might say, wow, just 2 doses is better than 3. Well, when the prevalence is so low, and these are 7-day averages in determining cases, the math is a little fuzzy here. Basically, everybody comes down to very little case rates when the prevalence of disease is low. So just keep in mind, we do see that it's better to be vaccinated and boosted, and then once there's not very much virus circulating, then everybody's pretty much equal. But when there's a surge, the vaccines did hold up. But not 100%, we still could get an infection despite being vaccinated. But the good news is our risk for death was was zero near, so the vaccines were 99% effective in keeping us from dying, which 2 years ago, that was what we were hopeful for. With the wild variant as well as Delta, the vaccines held up in protecting us against infection, period. However, when the Omicron surge occurred, we realized that we can still have breakthrough infection despite 3 doses. So let's talk about BA2, which is the second variant of Omicron. It is considered highly transmissible. One person can infect 12 people, and it is highly contagious. There is an increase, a theoretical increase in respiratory symptoms due to BA.2 due to its propensity to attach to the respiratory mucosa a little bit more significantly than BA.1. And it is currently estimated that up to 70% of circulating COVID-19, SARS-CoV-2, is of the BA.2 variant. In San Diego, it's 50%, 55%. On the East Coast, it's as high as 77 to 78%. Probably next week in San Diego, it'll be much higher. What about if you've had BA.1 in January? Will that protect you against BA.2 this month or next month? And there is some evidence to show that having prior BA.1 does confer some immunity against BA.2. The good news with Omicron, whether it's BA.1 or BA.2, is that the illness itself isn't resulting in severe pneumonia or low oxygen levels unless there's some immune compromise or you are not fully vaccinated. Then it acts like wild type coronavirus. What if you're going to get the fourth dose? They're recommending this fourth dose, but what is in it? Is it different than the first dose? And these are the vials from the original vaccine released last year. And no, your vaccine is the same as it was originally formulated against the wild SARS-CoV-2 strain. This is the Delta variant, and this is Omicron. And then if you imagine this all shaded in this cream color, that would have been the wild type. So the Delta variant and the wild type, the vaccine had held up pretty well. That it was estimated that the original vaccine formulation could handle up to about 20 to 30 mutations. And until then, the vaccine may not work as well. The Omicron variant has over 50 mutational changes of its spike protein, which is this product I'm showing you. And we do know that immunity wanes after about 12 weeks following the second dose and even the third dose. And that even after your third dose, you were only about 40 to 60% protected against Omicron. The fourth dose recommendation is due to the fact that we know the immunity wanes, and we know that at best we can get 40 to 60% against Omicron, so we want to try to get your immunity back up there. And here is a visual of vaccine effectiveness against symptomatic disease by Delta versus Omicron variants and the booster doses. So if you look at, and this is just the 3 doses. So if you look at 2 doses of the Chadox, which is the equivalent of J&J, and you got the Pfizer vaccine versus Moderna vaccine, the mRNA, great protection against Delta. We know that they waned at about 24 weeks into 0 against Omicron, which are the open circles. When you got the third dose, saw a good peak at 2 to 9 weeks, and then it started to drop off to 40% effective. And that's if you were boosted with the Pfizer. And Moderna held up a little bit higher, but only at best 60% at 9 weeks. Delta still stayed up pretty well at 99 to 100% protected. What if you got 2 doses of the Pfizer, which is the BioNTech, and then you were boosted with either another Pfizer or another Moderna? So we saw immunity waning after second dose, and definitely near zero after 2 doses of vaccine. So the third dose got people boosted up to about 60%, but then started to wane at about 10 to 12 weeks to 40% with the Pfizer boost. And this is Omicron. Consider the O's Omicron. And the Moderna held up a little bit better. It's 80% protective and then waned to 60%. So that gives us hope that maybe a boost will get folks up here again and get them through the BA2. Again, if you got 2 doses of Moderna, you had some immunity waning, but not to zero against Omicron. We still don't have long-term information. This is a UK study, but good protection against Delta, and both, again, if you got your third dose as a Pfizer or a Moderna, equivalent in terms of protection. So this is why some of the social media is saying Moderna is better. But if you've received your Pfizer, boosting with the Moderna is not a bad idea. So what about, why have I been a little bit uncertain, and other doctors are uncertain about the fourth dose? And that's because a lot of this information was released as a mandate that everybody should get this by the CEOs of the vaccine manufacturers, which isn't traditionally how we've practiced medicine, and it's now kind of become the norm through the pandemic. But we have not seen all the data supporting a fourth dose, and we've seen variable ages being used. In Europe, 65 and older and 80 and older were advocated in those areas that are having significant BA2 surges. But age over 50, there hasn't been any studies for that. So we're still waiting for all of this information to say what are the risk benefit advantages in folks to get the fourth dose if you are, say, 52 years old and otherwise healthy. So the CDC, following an early meeting with the FDA last week, which caught me off guard because I was expecting them to meet next week, has approved the fourth dose for both the Moderna and the Pfizer vaccines for people over the age of 12 who are moderately or severely immune compromised, anybody over 50, and then those who are 18 to 50 who have received the Janssen vaccine as their primary series and the booster. So those folks should get the mRNA vaccine. So the J&J vaccine is not advised any longer. So let's look at why some of the hesitation exists. So some of the data released from healthcare worker studies in Israel showed that, yes, we do see antibody waning about 9-fold from the peak following the third dose. By giving the fourth dose, you could restore that, but there was still breakthrough infection that was about the same as if you third dose versus a fourth dose. Same in Germany and same in Spain. If you look at the neutralizing data from blood tests done, you can see that after getting your second dose, you've got some antibody levels, and you get the fourth dose, so second dose, third dose, you get a little spike. And then if you boosted with the fourth dose, you're about the same whether you got the BioNTech, which is the Pfizer, or the Moderna. And these are week 1, week 2, week 3. And you're about the same as if you got the third dose. So that's one of the reasons we're not certain. We also have seen that neutralization of the live virus diminishes with Omicron. 5 months after the third dose, we can see definitely a waning. You get a little bit of a boost with the fourth dose, and I think this is why they're recommending it. But whether it protects you against symptomatic infection is less certain. And we do know that we we are still remain at risk for symptomatic infection, whether you got the BioNTech, Pfizer vaccine, or the Moderna. What should you do? Well, if you are at all worried, get the fourth dose. If you have any underlying clinical conditions that put you at risk for complication, where, COPD, asthma, you don't want to get sick regardless, or don't want to have severe complications, get the fourth dose. But I recommend mix and match. And the reason is, and we call that heterologous boosting. And the reason is that this study has shown that if you receive 2 Pfizers or 2 Modernas and you boost with the opposite, you get a little bit of a higher bump in your titers. Now, how will that translate to symptomatic infection? We don't know. This was a study group of healthy volunteers, so we don't know how it will translate, but I can tell you personally, I did that, had received 2 Pfizers and did a Moderna boost, and the CDC had recommended at that time heterologous dosing. If they said get whatever boost you can. And so at this time, for your fourth dose, I do advocate getting a different one. Now, why is there a low rate of boosting period? Right now, we can see that whenever there's a surge, there is an increase in boosting, and then it rapidly tapers off with the incidence of disease as it wanes off. So we do know that there are many people who are vaccine hesitant because after the first, second doses, they may have developed an arrhythmia. Many people have had arm pain that's in the site of their injection that lasts a month or two. Headaches can persist after the vaccine. And there's been some recent reports on tinnitus, which is ear ringing or hearing loss, in people who've received the Pfizer vaccine. So many of these reports get out and folks get hesitant and they get nervous and they say, well, I've made it through this surge. And then they avoid getting the boost. So just to keep in mind, billions of doses have been administered. So there will be some signals of these issues, but overall numbers are low. I think many people may hesitate saying, why bother getting a fourth dose if it's only going to protect me from symptomatic infection 40 to 60%, and it's not a perfect shield. So what about those who say, I've already had COVID, do I need a fourth dose? So that is now considered a hybrid immunity, and some studies from Brazil and Sweden find that there's the least reinfections in those who have been infected and vaccinated. And here is a study released in the New England Journal that I invite you to take a look at their video. And it shows that definitely vaccine effectiveness wanes with time. Greater than 6 months after the second dose here, you're only about 50% protected from the vaccine efficacy is only about 50%. But if you got an actual infection, there you can get a boost in your vaccine efficacy, 84%, and then up to 95% 1 year after primary infection. So this is interesting data. We don't know how it will play out. If there is an unknown mutation that comes down, what if there is another variant that's even worse than Omicron? how will our prior infection plus vaccination serve us? So that is the greatest unknown. What about if you are immune compromised, just diagnosed with cancer, getting chemotherapy, or you cannot be vaccinated? Well, there is hope. There is a monoclonal antibody called Evusheld, which is protective for you for 6 months. It's like giving you the antibodies that your body should have produced from a vaccine, and it's supposed to last 6 months in your system. Early on, they found out that this dosing was not quite as robust against Omicron. So, those who received the first doses in the first week of its release were asked to come back to get a booster for a double dosing. So, that's the standard dose now. You will have to keep it on your calendar and get re-administration of this monoclonal product every 6 months. Now, what if your immune status changes? You're no longer receiving chemotherapy and your immune system wakes up, so to speak. Well, then you may not need to get redosed, and we can talk about that in 6 months. And those of you who had an allergy or a reaction to COVID-19 vaccine, such as hearing loss or arthritis or migraines or something that makes it so that you really can't get your vaccine, then I would consider Evusheld. And please let me know and we'll talk about it. Now, what if you do get COVID? There are treatments on the shelf, this is the day we've been waiting for. In January and February, there were limited treatments available, and they were on allocation. And because they were limited on who could receive them, prescribers were hesitant to then recommend them and didn't even really consider them for patients. And so now they are sitting unused on shelves, which is unfortunate because we could decrease the incidence of disease or complications and hospitalizations if we use these a little bit more aggressively, which now is being advocated for by public health. So the products are Paxlovid, which we've mentioned prior, monoclonal antibody therapies we've talked about a lot, but the latest is bebtelovimab because the prior products do not have efficacy against BA2. Remdesivir is another therapeutic that has to be given daily over 3 days. So that means 3 trips for the recipient. And then another drug called molnupiravir, which is only about 40% effective in preventing hospitalization, but if used early and when these weren't readily available in many areas, many docs use this, and they said anecdotally it was very efficacious for their patients. I did prescribe a lot of Paxlovid in January and late December with some great responses where people said that within hours to a day of use, their fever and cough abated quite quickly. Now, many countries don't have some of these products, and a study was recently released showing convalescent plasma, if given early, does help also prevent hospitalization, which is actually our goal. What about the treatments in San Diego? There's tons of information on the county website. They've expanded the treatments pretty liberally because they want to decrease community transmission and try to keep our most vulnerable from getting infected. The therapeutics are still managed by the state and the county and the government through their pipelines and channels, and I'd looked into trying to get some of these. However, it would be logistically challenging because then we would be on the national locator website and be open to an entire city, and we just don't have the staffing to support distribution to entire cities. So I know we can use these locators and get you treated if you needed. There is something new called the Test to Treat and a website by the White House, covid.gov, where they're going to try to provide all of those locations. You just punch in your zip code. Now let's switch gears to what if you get COVID and you start having some prolonged symptoms and you're not one of those who got over the Omicron in 72 hours or even a week or 2 weeks. We call it the post-acute sequela of SARS-CoV-2 infection, or PASC, in the lay press called long COVID. The brain fog of long COVID has received a lot of press, and that one has shown that it is due to inflammatory mediators that are circulating as our response to the COVID infection. And that causes kind of a swelling and a lot of markers in our brain and can be debilitating to many. And studies showed that if you did a spinal tap on those with COVID who complained of brain fog and those who didn't, those inflammatory mediators were higher in those who were complaining of it. A question had come up during our live session that would the vaccine help in this case? And yes, the vaccine has been shown to help minimize long COVID symptoms. Asthma is definitely a sequela of COVID since the virus attaches to our airway and respiratory mucosa and causes inflammation and can turn on asthma or aggravate asthma. There is also something called interstitial lung disease or pneumonitis the scarring can become permanent and then result in need for oxygen long term. Autoimmune disorders can get turned on due to this robust inflammatory response in our bodies, and sometimes there's a long-term arthritis that can occur. Blood clots due to our robust immune response trying to fight this bug can occur. And there is a long COVID fatigue syndrome that can also occur. And that has been present in many people 6 months to a year. Interestingly, those who had lost their sense of smell or taste during their original infection, which doesn't happen as much with Omicron, but can happen, tend to have these ghost taste sensations that occur without any warning. And suddenly you could have your normal taste back, and then suddenly everything tastes salty for a week, and then go back or switch to bitter. A very interesting phenomenon that we are still learning a lot about. There's a cardiomyopathy that has been discovered due to the direct attack of the virus onto the heart muscle. And we do know that arrhythmias are also a sequela of COVID. What about ivermectin? So there have been over 3,000 people studied in Brazil on the use of ivermectin, and the goal is in preventing hospitalization or going to the emergency room or a prolonged ER stay. And of all the people in the study, they were able to isolate 100 people who had received their positive PCR tests early within their disease in the first 7 days of symptoms, and they got ivermectin versus a placebo group, and they tracked them very closely to see what percentage required hospitalization or a prolonged ER stay. Due to the surge of COVID in Brazil at the time, they ran out of hospital beds, so they couldn't use hospitalization as an endpoint. And they found that there was no significant difference between the two groups. The study was well done and matches most of our clinical experience. Steve, what about influenza? I'm switching gears now because the current circulating, there is an uptick in flu cases currently in San Diego. Not a lot, not like we normally see, but due to all the mask relaxation policies and folks are gathering indoors and making up for lost time. And we are seeing an increase in respiratory illnesses and influenza. And the type currently is influenza A, and a subtype that is not in the current vaccine that was administered last fall. Although overall cases are low, but we may see an uptick. So if you do develop flu-like symptoms, which is the same as Omicron-like symptoms, sore throat, fever, headache, body aches, let us know. We can test you for both COVID and influenza and treat accordingly. The earlier we know, the better. I thank you for your attention and can answer any questions by email or give me a call. Take care.